Thank you for your kind invitation. Today I will speak about the management of a complicated cataract surgery and secondary lens implant. So the outline of my presentation is the zonula weakness and dialysis. I will speak about the lens iris diaphragm retropulsar syndrome, stabilization of a capsular bag, anterior bimanual vitrectomy, and 3 pieces IOL implant. We will also speak about the UGH syndrome, uveitis glaucoma ephema syndrome, and the secondary IOL implant, so scleral and iris fixation. So let's start from the zonula dialysis. So it can be related to congenital conditions like Marfan syndrome, homocystinuria, but also congenital aniridia syndrome, and acquired condition like pseudosphoricio syndrome and retinitis pigmentosa, or also previous pars plana vitrectomy. First of all, we need to assess the degree of zonula loss. So that can be minimal or mild if it's between 0 and 25% of the pupillary area, or moderate between 25 and 50, or severe if it's more than 50%. We need to also assess the zonula status, looking at the equatorial edge of the lens, if it is flat, and we need also to look at phacodonesis, density of the lens, and the presence of vitreous in anterior chamber. Let's speak first about lens iris diaphragm retropulsar syndrome, or reverse pupil block. Is a deepening of the anterior chamber during the phacoemulsification with the pupil dilatation, and we will have a concave shape of the iris that stays attached to the anterior capsular rim. The pathogenesis is related to the pressure in anterior chamber, so the pressurized fluid into the anterior chamber because of the phacoprobe, and the fluid cannot reach the posterior chamber and the vitreous chamber because the iris and the lens is displaced posteriorly. So the predisposing factors in this case are weak ciliary muscles and elongated and stretched zona. We need to equalize the fluid pressure between the anterior chamber and posterior chamber. So basically we need to lift anteriorly the iris. So we need to reestablish the communication between the anterior chamber and posterior chamber. You can easily see the maneuver in the videos. And so I'm just lifting the iris and the fluid is going through. Just lowering the bottles of the infusion is not enough. We'll only have instability of the anterior chamber and the shallowing anterior chamber. Now let's analyze every single surgical step in presence of zonular damage. First of all, the capsulorhexis. It's better to puncturing the anterior capsule instead to open just with the forceps, because the sharp cystotome help us in induce less pressure on the lens. Then we can use the trypan blue. Of course, the aim is the visualization, but the trypan also reduces the elasticity of the capsule. And then if we can, it should be better to inject just a few drops of the trypan across the visco in the anterior chamber, instead to irrigate the anterior chamber with the trypan blue, because of course can cause turbulence and can induce a further displacement or damage of the zone. Regarding the femto laser is of course useful in these cases, so it's able to cut the capsulorhexis despite subluxation of the lens, as long as the lens of course is not tilted excessively after the docking. Regarding the stabilization of the capsular bag depends on degree of subluxation. So capsular tension ring is important, an important step, but when the degree of subluxation is less than 3 hours. Otherwise, we need to use capsular hook, and these hooks are different from the iris hook because they have an angle to be in the plane of the anterior chamber. Then we can use a Chonny ring or hammered segment, and they can be fixed on the sclera with the Prolene 9 on 10-0. And then we have the ASI anchor that can use not the intra, but just in the post-op, and also has been fixed with the Prolene. Sometimes we can also combine the capsular tension ring plus hammered segment in case of damage larger than 4 hours clock. Regarding the hydrodissection, needs to be performed in all eyes, sometimes several times, and it's better to use a dispersive instead of cohesive OVD in order to keep the balance of the pressure. Regarding the phaco emulsification, we need low aspiration. We need to prefer the chopping more than phaco to induce less stress on the zonula. And then regarding the cortical material, of course, we need to avoid to induce a further stress on the zonula, so tangential stripping in meridians distant from the adhesions, and so stripping from margin to the periphery in order to minimize the strain. This is an example of a surgery in a Marfan syndrome, 54 years old male with a severe degree of zonula loss. And so what I did, I was creating an artificial capsular support with 4 hooks. I was doing, as you can see here, the capsular axis, first incision with the cystotome, because it's sharper, as I was saying. Then I was placing the 4 hooks, and I was creating an artificial zonula to support my phaco emulsification. And the aim is to avoid to drop the lens down and to induce a further traction on the vitreous space. And then doing the hydrodissection several times in order to be sure. You can see also the ring of the hydrodissection, and I was also doing the hydrodissection from the other side, okay? And then phaco emulsification, and okay, flipping the nucleus. Okay, the capsular bag is still in place. You will see by the end of the surgery. Of course, you need to start with the low levels of flow rate and infusion in order to minimize the turbulence. Then was cleaning everything with EA. And at the end, everything was done. The vitreous was not present. And I was just removing the hooks, the antagonist one at the same time. Okay. The capsular bag was still there. And at the end, I was removing also the capsular bag because it was completely displaced, and I was putting an artisan lens. Sometimes is also possible to shift from Chonny ring that we are using with the help of hooks during the surgery. We can shift to a standard capsular tension ring by the end of the surgery. In terms of fixation long term, we can fix then with the Prolene, the segment or the ring, with a scleral corneal pocket or a scleral flap, or just over the episclera. We need also to remember that the dislocation of the capsular tension ring, IOL, and capsular bag complex is possible and occurs about 7 years after the surgery. So if the zonula is healthy, we need to remember that the capsular tension ring plus IOL decrease the postoperative zonular stabilization. So if we don't have to use the capsular tension ring combined with IOL, because increase also the tilt aberration after cataract surgery and does not improve the optical performance of IOL. Another tip for this surgery that the IOL should not be implanted until an adequate anterior vitrectomy has been performed. So the anterior bimanual vitrectomy aims to remove the vitreous prolapse and the adhesion between the vitreous and the anterior chamber structures. So we need in one end the vitrectomy probe, we need to place a separate infusion, and then we need to have another paracentesis for a spatula, for something, for a third, so a second instrument in the third corneal paracentesis. The potential complications related to the presence of vitreous in anterior chamber are traction of vitreous base, that means retinal tear, retinal detachment, and ophthalmitis, because the vitreous stents in the corneal incision can act as a medium from the incision to the vitreous, and can also lead to corneal edema, secondary glaucoma, to the direct contact between the vitreous and the anterior chamber structure, and can also induce residual traction, so inflammation, vitreitis, and cystoid macular edema. What about the size of the cutter for anterior vitrectomy? If you can use small cutter is still a better option, because in order to minimize the traction, we need to have a small port, so 25 or 27 gauge vitrectomy with high cut rate should be preferred, because will induce less traction to the vitreous base. Additional tips are separated the infusion, so with a third paracentesis with an AC maintainer, and also the vitrectomy probe can be used via both corneal incision and or pars plana incision, and this allows a greater freedom of movement, more accurate cleaning when we'll indent from the outside the sclera. So depressing the sclera, we can better shape the vitreous base, and we can go through the pars plana, or we can also go through the anterior chamber. Of course, if we use a small vitrectomy, we will have a smaller corneal paracentesis. We minimize the prolapse and incarceration of the vitreous in the anterior paracentesis. Again, the coaxial vitrectomy is not recommended. So the infusion is to be separated from the cutter. So because the coaxial infusion can induce a repulsion of the vitreous fiber, the vitreous escape and entrapping into the wound. Then we can also extend the PC rupture because of the hydration of the vitreous, and so the infusion movements parallel those of the cutter extend further the PCR. Regarding the IOL implant, we can, of course, is the best option if we have enough capsular support. Regarding the power of sulcus IOL implant, if the patient is hypermetropic, the reduction is 0.5 diopter. If is emetropic, 1 diopter. If is myopic, is 1.5 diopter. And sulcus IOL should have a posteriorly adequate and thin looped optics, and overall length of IOL at least 13 millimeters. So the sulcus is the preferred location but needs, as I was saying, an adequate capsular support, and it's better to remove the summer ring that can avoid than the anterior displacement of IOL optic. So in case of insufficient capsular support, we can have, trouble problem. As you can see here in this video, where we have the two optics of three-piece IOL on the sulcus, but the IOL at the end was displaced posteriorly because there was an absence of an anterior continuous capsular X on 360 degrees. As you can see here, I was placing in the sulcus, but after a few seconds, the IOL was displaced again on the retina. As you can see here, you see this place. And regarding the scleral implant, intrascleral implant, in the same cases, what we did, we just did a scleral access. We took the loops out, we did the tips and create a plug, at the tip of the loops, and we were rotating the lens in order to translate the tips of the loops into the sclera below the conch. And at the end, you can see that was placed and the tips were under the conch and inside the sclera. If you see here, the lens was implanted all the way around, so upside down. So we had to, to reverse the IOL, okay, as you are seeing here, okay. And then I was also doing the vitrectomy, placing the infusion anterior to the IOL and the cutter under the IOL in the vitreous chamber. In this way, you can keep the infusion up, and you can cut, the vitreous instead to, bring the vitreous in the anterior chamber. So use the IOL as a barrage between the anterior and the posterior chamber. Regarding the single pieces IOL implant can induce, the UGH syndrome. We'll see later. So the sulcus placement of a single pieces acrylic IOL results in several complications: UGH syndrome, secondary IOP elevation, pigmentary dispersion syndrome, and lens decentration. So we don't have to use this kind of lens in case of PC rupture. And the uveitis glaucoma famous syndrome is mainly related to the anterior chamber IOL and one pieces IOL. The mechanism is because it's a mechanical chafing of uveal tissue by IOL, breakdown of the blood aqueous barrier, chronic inflammation that leads to uveitis, dispersion of pigment that leads to glaucoma, and edema. At the beginning, we can try, in case of mild disease, medical management, but most of the time is not enough. We need to remember it's better to avoid pilocarpine that is contraindicated in UGH syndrome, unlike in pigmentary glaucoma. When we need to exchange or remove or reposition the IOL, so is recommended to repositioning the IOL in the first line, and then in case of persistent anterior chamber inflammation, iris transillumination defect, or pain, grade 4 pain, standardized pain numerical rating scale, we need to remove and exchange the IOL. What we can use? We can use different type of lens, and anterior chamber IOL, but is not recommended anymore, or iris or scleral IOL. Iris can be anterior iris claw, retropupillary iris claw, or 10-0 polypropylene iris suture PC IOL. Regarding the scleral one, can be suture or intrascleral. The suture one can be sutured with the Prolene or with the new Gore-Tex sutures. So regarding the scleral fixated or iris claw IOL, the pro for the scleral fixation, they have no corneal and angle trauma, little to no contact between IOL and iris, but the contra are technically challenging, need an anterior vitrectomy done, and the haptic contact with the uveal tissue can induce inflammation. Regarding the iris claw, the pro are that is an easier technique, shorter operative time, no angle trauma, but the contra are the chronic iris chipping, need of iris support and larger corneal wood. And there are also reports regarding the endothelial cell density reduction. In a study published on IOVS 2017, between scleral fixated and iris claw IOL, there was no statistical difference in terms of visual acuity, yaw dislocation, cystoid macular edema. Regarding the placement anterior or posterior to the iris, the prepupillary implantation seems to have a greater endothelial cell loss and also earlier onset of cystoid macular edema. So nowadays it's preferred to implant behind the iris, but we need to also know that we published this paper that the force transmission in case of posterior implant are higher. So we need to have an adequate amount of iris tissue that's enclavated during the posterior implantation. Otherwise, we have high chance to have a dislocation of the iris claw implant. Regarding the intrascleral haptic fixation, it has been described in 2010 for the first time, and then Yamane published 2014 this technique using a 27-gauge needle and the 3 pieces IOL. Then he cauterized the tip of the haptics. And the key of this technique, of course, is the symmetry of the implant, intrascleral implant. This is a video where you can see that I was placing the intrascleral loop first, okay, and then the second one. Okay, then I was cauterizing both. You don't have to touch, just to be nearby, but you don't have to touch. To then rotate a bit in order to bring the tip inside the sclera. And okay, and this was by the hand. We also have now, since a few years, a Carlevale lens. This is a hydrophilic acrylic single-piece intraocular lens. There are few publications, but it seems that the cystoid macular edema rate is between 3–5%, so quite low. Few cases of ocular hypertension or pigment dispersion that are about 6%. The video, as you can see here, is placed as 2 haptics and we can bring the outside of the sclera from one side, the outside of the sclera on the other side, and then you can place it in the scleral pocket or under a scleral flap. Finally, I want to just report this meta-analysis where 45 papers were selected in comparing the anterior chamber IOL, posterior chamber IOL, and iris claw. So at the end, regarding the evidence, most of the articles were in level 3 of evidence, so were only case series. And we can see that the revision shows no superiority of any single IOL implant technique in terms of better zonular support. We can see that in the sclera, in PCIOL, scleral PCIOL, we have a higher chance to have tilting. And the intrascleral one, we have a higher chance to have pupillary capture, whereas in the anterior chamber iris retropupillary IOL, we have a higher chance to have cystoid macular edema, and in the scleral PC-IOL, higher chance to have chronic glaucoma. So the surgeon must educate patient on the importance of long-term follow-up as a result of uncertain nature of this technique. Thank you for your time.